Homosexuality, Clinical and Biblical Perspectives. Controversy abounds about homosexuality, especially in recent days, given the pronouncements of certain societal leaders, media practitioners, clinicians, and clergypersons. The controversy no doubt will continue on both the moral and the clinical fronts, but there are some non-controversial realities concerning homosexuality, and these need to be more widely known and appreciated, especially by governmental authorities who struggle with legislation on the issue, and also by religious persons who seek to be involved in the ministry to homosexuals. It is my intention to explore, in the first place, aspects of human sexuality, then a specialized look at some clinical realities on homosexuality. The second thing I wish to do is to take a look at the Bible's view of homosexuality. Let us begin with an understanding of human sexuality. Here we are trying to simplify a complex reality. Human sexuality involves three basic components and can be seen as the sum of these three basic components: sexual identity, gender identity, and sexual orientation or preference. But what exactly is involved in these three components? Sexual identity has to do with your genetic makeup, the particular combination of X and Y chromosomes that make you who you are, basically. The genes of your being and your hormones determine how you look physically, biologically, in terms of being male or female, and they also determine the intensity of your sexual desire. Sexual identity, then, is an objective biological reality. Gender identity has to do with your inner sense, your picture of yourself as male or female. This is largely determined by social and psychological forces, and is formed during infancy and childhood. Gender identity, then, is a subjective psychological reality. Before explaining the third component, let me deal with a crucial fact about sexual identity and gender identity. Sexual identity and gender identity can clash. Your inner picture of yourself, your gender identity, can be different from your outer biological or physical look, your sexual identity, and change of one of the identities may be deemed necessary. This clash of identities happens with some people who are biologically normal. By that I mean people who are, by virtue of chromosomes, either XX and thus female, or XY and thus male. The clash of identities can be even more pronounced for people who have rare combinations of X and Y chromosomes, as well as for those who have the normal combinations but suffer from some hormonal abnormality. When the identities clash, someone may become a transvestite. Take the vest in transvestite to represent one's normal vest or clothing, and trans to mean beyond. Transvestites, then, seek to go beyond or alter their outer vest or clothing to look like the opposite sex, consistent with their inner feel. There is another option when the identities clash. Someone may seek to become a transsexual, seeking surgery to alter the physical appearance to match the inner picture of the self. The third component of sexuality is sexual orientation or preference. These two words are not really identical, even though they both have to do with whom, gender-wise, or with what you normally desire to have sex. Orientation is generally the preferred term because preference has an element of choice implied in it. To recap then, sexuality is sexual identity plus gender identity plus sexual orientation. Put differently, and less precisely, your sexuality relates to who you are sexually, whom you feel like sexually, and whom or what you feel for sexually. Let us now look briefly at the basic sexual orientations. The first and seemingly the most widespread sexual orientation is heterosexuality. The prefix hetero, H-E-T-E-R-O, is derived from a Greek word meaning another of a different kind. So heterosexuality is an orientation for male-female sexual intercourse. Another orientation, and the focus of our presentation here, is homosexuality. The prefix homo, H-O-M-O, is not derived from Latin meaning man, but is from a Greek word meaning same. So homosexuality is an orientation for same-sex sexual intercourse, that is male to male or female to female. Indeed, some clinicians use the expression same-sex attraction as an alternative to homosexuality. A third orientation is bisexuality, and the prefix bi, B-I, is from Latin meaning two. Bisexuality is an orientation for sexual intercourse with both male and female. The fourth orientation is bestiality, B-E-S-T-I-A-L-I-T-Y. This orientation is for sexual intercourse with a lower animal or beast. The final orientation, if we can call it that, is asexuality, A-S-E-X-U-A-L-I-T-Y. Asexuals lack a desire for sexual intercourse. How does anyone end up being of a particular sexual orientation? Is homosexuality a genetic or biological reality, or learned behavior? There is much that we can learn from clinical and cross-cultural studies to help us answer these difficult questions. Let's begin with cross-cultural studies. Despite the remarkable similarities in the genetic characteristics of different ethnic groups, researchers have found quite a variety of sexual norms and customs in the cultures studied. There is variety in heterosexual customs, as well as variety in homosexual customs. And these varieties seem largely influenced by what a particular group reinforces in the raising of the young. If sexual orientation was essentially genetic, then cultural anthropologists would have seen a greater degree of similarities in sexual expression within, between, and among the various ethnic groups studied. Focusing on homosexuality, it needs to be said that cross-cultural studies indicate cultural patterns that have little to do with an individual's genes. For instance, one prominent aspect of ancient Greek culture was that an older married man was expected to have a young boy as a lover. He would share sexually with the boy and would assist in finding him a wife when he was of marriageable age. Interestingly, the Greeks, though comfortable with homosexuality between a mature man and a boy, frowned on homosexuality between adult men because it was degrading for a mature man to be receptive in the sex act. Patterns similar to the Greeks have been found in ancient China, Japan, medieval Persia, the Sudan, etc. There is also what is called the Melanesian model of homosexuality, seen in Papua New Guinea. According to this model of homosexuality, men pass through 3 compulsory and sequential stages: passive, exclusive homosexuality, active, exclusive homosexuality, and exclusive adult heterosexuality. the culture not only requires homosexuality through the adolescent period and up to the age of marriage, but requires a cessation of homosexual activity after the required period had elapsed and a switch to heterosexuality. As Neil and Briar Whitehead say about this cultural reality, quote, two such radical shifts in behavior in one lifetime would not be possible if homosexuality were genetically mandated, unquote. This is page 101 of their 1999 book, My Genes Made Me Do It, a scientific look at sexual orientation. There seems to be a sizable cultural component to sexual orientation and practice. The genetic or biological thesis does not find much support from cross-cultural studies. Could the clinical side provide the support needed? Let's turn to that now. We begin with a summary statement from Masters, Johnson, and Kolotny. They say, quote, the genetic theory of homosexuality has been generally discarded today, unquote. This is from page 45 of their 1984 book, Human Sexuality. Why this blanket statement? From a clinical standpoint, it is notoriously difficult to prove that any human behavior is genetic in an exclusive sense. Additionally, clinical research on identical twins has been damaging to the genetic or born homosexual thesis. Why are studies on identical twins so important for homosexual research? Just think a bit. If one's genetic makeup is the essential factor which makes one homosexual, then if you have identical twins of the same genetic makeup and one is found to be homosexual, then the other must also be homosexual. You would have to have a concordance rate of 100%. You should not find a discordant pair at all, where one is homosexual and the other heterosexual. So what are the clinical results of the studies done on identical twins like? Let it be clear that no study of twins that still attracts respect in the scientific world has come close to the 100% concordance rate needed to prove that homosexuality is genetic. Franz Kallmann claimed 100% for his study, but his sample was largely drawn from the mentally ill and institutionalized. Bailey and Pillard got a 52% concordance rate, and King and MacDonald got slightly less than 50%. We say again that the genetic thesis fails if there is not 100% concordance, and there has not been. But what of studies done on the brains of homosexual men? Dr. Simon LeVay is alleged to have found a difference in the brains of homosexuals and heterosexuals, which some assumed helped the born so or genetic thesis. It is critical, though, to hear LeVay's comments on his own work. He urges, quote, "It's important to stress what I didn't find. I did not prove that homosexuality is genetic or find a genetic cause for being gay. I didn't show that gay men are born that way, the most common mistake people make in interpreting my work. Nor did I locate a gay center in the brain." End quote. This is in an article by Dr. A. Dean Bird and others in the Salt Lake Tribune, May 27, 2001. However politically correct it might be to claim that homosexuals were born so The claim is clinically incorrect. The question remains, though, how does homosexuality as an orientation arise if one is not born that way? There are several factors to consider when dealing with the origin and nature of homosexuality. As Jeffrey Satinover says, quote, "Like all other complex behavioral and mental conditions, homosexuality is multifactorial. It is neither exclusively biological nor exclusively psychological, but results from an as yet difficult to quantify combination of genetic predispositions, intrauterine influences, some innate to the mother and others incidental to a given pregnancy, postnatal environment, parental and sibling behavior, and a complex series of reinforced choices occurring at critical phases in development," unquote. This is in Homosexuality and American Public Life, edited by Christopher Wolfe, 1999, page 13. In the same book, Richard Fitzgibbons calls homosexuality same-sex attraction disorder and suggests some contributory factors to the condition. He says, quote, "The three most important risk factors for the development of SSAD, that is same-sex attraction disorder, in men are weak masculine identity, mistrust of women, and narcissism. The major conflicts that lead to SSAD in women are, in my opinion, a mistrust of men's love, a weak feminine identity, or intense loneliness," unquote. Pages 87 and 90. What does Fitzgibbons mean by these risk factors and conflicts leading to same-sex attraction or homosexuality? Concerning male homosexuality, he identifies weak masculine identity as one risk factor. Fitzgibbons says this can be an outgrowth of weak eye-hand coordination, resulting in reduced ability to play sports well, attracting peer ridicule and rejection, and affecting gender identity. Poor emotional relationship with a father is another facet of weak masculine identity. Fitzgibbons says, quote, "A number of therapists characterize the childhood experiences of the homosexual adult as a form of defensive detachment from a disappointing father. As children and adolescents, these men yearned for acceptance, praise, and physical affection from their fathers, but their needs were never met," unquote. Page 88. A poor estimate of his own body and a corresponding obsession with the look of other men's bodies is yet another facet of weak masculine identity. The second risk factor for same-sex attraction in men, according to Fitzgibbons, is mistrust of women. This can arise from a difficult and demanding relationship with one's mother or another woman or women. Another contributory factor could be romantic or sexual betrayal by a woman. The final risk factor for male same-sex attraction disorder is narcissism. Fitzgibbons says, quote, "The narcissistic person is preoccupied with fantasies of unlimited success, power, brilliance, beauty, or ideal love. For the homosexual narcissist, the goal is a pursuit of pleasure," unquote. Page 89. Same-sex attraction in women, argues Fitzgibbons, arises from three major conflicts. The first is mistrust of men, possibly spawned by a father who was emotionally insensitive, alcoholic, or abusive. Traumatic experiences like being sexually abused or raped as a child or adolescent, or having been betrayed by a man after a long-term relationship, can also contribute to the residual mistrust of men. Another conflict in female same-sex attraction disorder is a weak feminine identity, largely triggered by a mother who was emotionally distant and not affirming of her daughter's femininity. Rejection by peers and a poor body image are also contributory factors to a weak feminine identity. Loneliness is the final conflict identified by Fitzgibbons that could lead to female homosexuality. After waiting or searching for the right man in vain, loneliness and disillusionment can lead to an easier route to a sexual relationship. The homosexual orientation, then, is more a result of compound nurture than simply nature, and there is, as yet, no clinical evidence of a genetic base for the orientation. I repeat, there is, as yet, no clinical evidence of a genetic base for the homosexual orientation. I want to address now an uncomfortable dimension of the homosexual lifestyle with which governmental officials especially, and Christians who seek to counsel homosexuals must grapple. I want to deal with some shocking realities of the homosexual lifestyle. Though there are people who admit to a homosexual orientation but remain celibate, or some who are sexually active but remain faithful to one partner, such homosexuals are very rare. One incontestable hallmark of the homosexual lifestyle is sexual promiscuity, admitted even by homosexual researchers and by sympathizers with the homosexual cause. A few indicative quotations should convey the picture. Quote, "Promiscuity among homosexuals is well known. Promiscuity is much more prevalent among male homosexuals than female homosexuals. But even female homosexuals tend to be promiscuous by heterosexual standards." Unquote. That's Frank Dumas. Not sure his pronunciation is Dumas. It's spelled D-U, capital M-A-S. This is cited in Grant and Horn, Legislating Immorality, page 34. Another quotation, quote, "Anonymous promiscuous sex is a hallmark of homosexuality, and this can be true even in what are called monogamous relationships. New York Magazine lamented the case of one AIDS sufferer who had, ironically, a rather stable sex life, staying with the same lover for more than 10 years, except for one night a week. That makes at the very least over 50 partners a year, and possibly 500. That's David Chilton, National Review, November 1, 1985. Here's a quotation now from Thomas Sowell, cited in Grant and Horn, Legislating Immorality, page 37. Quote, "Homosexual men have been attracted to the toilets at the University of Florida from as far as 40 miles away. This university, as well as Dartmouth, Georgetown, and the University of California at San Diego, have been forced to install stainless steel panels between toilet stalls to prevent the drilling of holes in the walls for homosexual activity." Unquote. The homosexual lifestyle is not only marked by promiscuity, but by abnormal and downright unhealthy, even pathological behaviors. Here's a quotation. from Grant and Horn in Legislating Immorality, page 265, note 66. Quote, a study in the New England Journal of Medicine found that on average, homosexuals ingest the fecal matter of 23 different men each year. Indeed, in a nationwide survey, 17% of homosexuals said that they eat their partner's feces or smear it on themselves, and 12% say they give and receive enemas as a part of sex. Meanwhile, some 40% of all those surveyed admitted to showering in their partner's urine from time to time. Unquote. In an age of AIDS and other sexually transmissible infections, it is difficult to avoid the societal implications of homosexual promiscuity and involvement in abnormal and unhealthy sexual deeds. It is time now to raise another politically incorrect but necessary clinical question. Can the homosexual orientation and practice be reversed? Homosexual activists and others would say no, but there is contrary clinical evidence. One of the persons providing a slice of the contrary evidence is Dr. Robert Spitzer, a gay affirmative psychiatrist and the architect of the 1973 decision to declassify homosexuality as pathological in the Diagnostic Manual of the American Psychiatric Association. His preliminary comment on a study he's doing about the possibility of change in the homosexual orientation is this, quote, I am convinced from the people I have interviewed that for many of them, they have made substantial change toward becoming heterosexual. I think that's news. I came to this study skeptical. I now claim that these changes can be sustained, unquote. Cited in an article by Dr. A. Dean Bird and others in the Salt Lake City Tribune, May 27, 2001. It should be noted that Dr. A. Dean Bird, lead author of the article I just mentioned, is a leader in the National Association for Psychoanalytic Research and Therapy of Homosexuals, NARTH, N-A-R-T-H, which was founded in 1992 by those psychiatrists who, contrary to some of their colleagues in the APA, sustain the view that homosexuality is a disorder and changeable. NARTH has superb material on its website. Check it out. Bird and his colleagues in the same article contend, quote, in reviewing the research, read Change Therapy, Jeffrey Satinova reported a 52% success rate in the treatment of unwanted homosexual attraction. Masters and Johnson, the famed sex researchers, reported a 65% success rate after a 5-year follow-up. Other professionals report success rates ranging from 30% to 70%, unquote. Richard Fitzgibbons, whom we have drawn on earlier on the factors leading to same-sex attraction disorder, supports the change thesis. He counsels, quote, we have treatment for weak masculine and feminine identity, for mistrust of those of the opposite sex, for betrayal anger, for sexual addiction, and for the other conflicts associated with same-sex attraction disorder. As a therapist, I deal with the psychological. Yet I must admit, there is little meaningful healing without the use of spirituality. If we combine spirituality and good psychotherapy, we can expect resolution and healing for those who struggle with same-sex attractions and behaviors, unquote. This is in Homosexuality and American Public Life, edited by Christopher Wolfe, 1999, page 97. Clinically then, homosexuality, though a complex behavioral disorder, is not a genetic or born-so issue, and change of the disorder is possible.